All right, guys, this is Dr. Scott, who's a former resident. Procedural mishaps is generated, it's been generated and designed just for you all as GPs. These are some mishaps that you guys will have, may have when you're doing endo. So Dr. Scott, take it away.
All right, good morning everybody in New York. I'm coming live from Houston, Texas. I was a former resident back in 2010 to 2012. I did 2 years there. I'm now practicing endodontist in Houston, Texas. Thanks to Dr. Hayes, this morning I'm going to talk to you guys about some procedural mishaps that you may encounter when doing endodontics. The title of my lecture is called You Do Endo, with a question mark, because I want to make sure that you understand that endodontics is a difficult procedure. Most of the treatments are done by general dentists, and you can do them successfully as long as you know what you're going to encounter. All right, my email address is dscottdds@gmail.com. If you have any questions or anything you want to contact me ever, feel free to email me at that email address, okay? All right, the objectives of this lecture are going to be for you to recognize any procedural accidents that may occur, and you're going to also be able to identify any causes, prevention, and treatment of these accidents. And the ones that I'm going to cover are accidents during procedural access preparation, cleaning and shaping of the canals, and when you're actually obturating the case, filling the root canals. Now, endo, a lot of us have fear factor involved. A lot of you guys are fresh out of school. Some of you have more experience than others. But proper case selection is one of the most important things when it comes to doing root canals, okay? You gotta be able to identify what cases you can and cannot do. That's your #1 goal, okay? Your knowledge that you gain in school or in your own experience are gonna help you with that. And knowing how competent you are, in doing root canals will also help you avoid a lot of these mistakes. And of course, I'm an endodontist, so I'm gonna put on there, you gotta know when it's time to refer to the specialist. Not every case is a GP case, okay? There's a famous study that a lot of endodontists will quote. It's called the Toronto study. It was done by Dr. Friedman and his group. It's a long-term study where they basically studied initial root canal treatment on patients who had apical periodontitis. And what they found out was that no complications in your root canal. Most root canals are successful, about 84% success rate. That's pretty good, even for general dentists and endodontists combined, okay? But as soon as there's a complication involved, you see the success rate drops pretty drastically to 69%. This first picture here, I don't know if any of you seen this in any cases that come across your desk, or maybe a case that you've been involved with, but as you can identify here, that this person tried to access this tooth through what appears to be a multi-surface crown possibly, or even a large gold restoration. But anyway, a perforation has occurred, as you can see on the mesial wall, and even it looks like on the floor of the chamber there. So perforations during access preps, what usually causes them to occur? Most likely it's going to be an anatomic variation, or even the dentist's lack of attention. You just say, oh, I'm going to open this up. It's going to be the same as every other molar I've ever done, and then end up perforating the tooth. And sometimes perforations even occur on anterior teeth, believe it or not. I don't know if you guys have worked with Dr. Wiener yet, but he always used to tell me to stop and check, make sure I know what I'm doing. Sometimes it's best to look at the radiograph preoperatively and measure how far it is before you get to those pulp chambers, and even put a little stopper on your burr. I know that might make you feel like you're back in dental school, but trust me, I still use a slow speed handpiece. I'm not ashamed to admit it. I'd rather be safe than sorry. So during your access preparations, you want to use all your tools. Everything that's in your armamentarium, you want to use them, okay? And I'm going to go back to what I mentioned before. Your clinical exam is important. Some teeth are rotated, especially underneath of crowns. You may think it's a straightforward tooth, but underneath of that crown, the chamber is actually rotated. So that's why all endodontists usually take 2 different angle x-rays, and we also take a bite wing. Those things will always help you during your access preparation. All right? Whenever you're using apex locators, they are very helpful in detecting perforations. If you put your file in and you hook your apex locator up, and the apex locator just starts beeping up and down, going kind of crazy like this, most likely you perforated the tooth. Okay, that's a little tidbit for you to remember. And one thing that you all should have is called Endo Z burrs. Make sure you write that down. It's called Endo Z burrs. These burrs cannot cut on the bottom. They only cut on the side. All right, so if you perforate with an Endo Z burr, you might want to reconsider doing endo at all, okay? Next thing I like to bring up is called the fiber optic light. Always have a light on your loops whenever you're doing endo. I don't want to see any of you guys doing endo without loops and the light. It's just not a good idea. You're setting yourself up for a bad situation. All right, and I put on here 2.5 or higher. Most endodontists are going to be using 6.0 endo loops or at least 4.5s. So if you guys are going to be doing a lot of endodontics, you might want to invest in at least some 4.5s, okay? And the DOM is obviously the dental operating microscope. That could be cost prohibitive, but it's something that we use definitely in our specialty. But I do know a lot of GPs are investing in it also. It's not that hard to use once you kind of get the hang of it. So in case a perforation does happen, what are you going to see? You might see some blood, some fresh blood coming out of the tooth. You think it's another canal. You stick your file in there, and that apex locator just starts going like this, up and down, up and down. It's most likely perforated, like I said. So the first thing you want to do is take an x-ray to confirm that, all right? But you can treat perforations, and they can be successfully treated. There's some studies out there that talk about how to treat them. So I'm just going to briefly go over that just in case it does happen to you, okay? If you do perforate the tooth above the bone, that's a very favorable prognosis. It can be fixed up and repaired, okay? We're usually going to repair it with a restorative material such as MTA. I'm sure a lot of you have heard about that, or even biodentin. I like biodentin because it's a lot easier to use. I'm not sure if you have any in the clinic. It's not as expensive as MTA, but like I said, it's a lot easier to use. I kind of feel just the consistency, I can put it exactly where I want to place it a lot easier than the MTA. The MTA is very technique sensitive. Sometimes we have to get perio involved, meaning flap the gingiva and repair the perforation, or even just the full coverage crown just to cover up where the perforation may be after it was repaired with the biodentin or the MTA. Now, sometimes that perforation goes below the bone. These are your porous prognosis. It's just a lot harder to fix because you got the saliva, you got the blood. It's just the environment is a lot different there. So sometimes it takes a lot more to fix those type of perforations, and that's even if the patient wants to go through with it. I'll put on here some ortho extrusion, some crown lengthening. Like I said, back to MTA, we're going to use that below the bone because of the blood. MTA loves to be in that moist, bloody environment. So like I said, that's going to be a much more difficult procedure, okay? In some cases, even require surgical intervention to repair the perforation. Here are 3 studies that are pretty famous also. The authors are on the left. And they're going to tell you that the prognosis of a repair, as long as it's repaired pretty much immediately, you have a pretty good chance of success. Now, if the tooth's all infected already and you just close it up and you send the patient on their way to the endodontist to get it repaired, they don't come see me for a month or 2 months, the prognosis is going to drop drastically. So you see the lowest number on here is 86% at 3 years. So you can imagine that that number will drop the longer it takes to repair that perforation. All right, so these are the ones that I think, other than the perforation, you guys are probably going to want to know the most about. Doing your cleaning and shaping. You want to take your time doing this because you're going to have these type of mishaps that you could encounter, okay? Ledge formation, the separated instruments, and the extrusion of the irrigant. This one looks a little blurry. I'm sorry for that image, but as you can see, maybe you've done a root canal and it came out like this, and you're wondering, man, why did my cone go all the way down to the apex? I did everything right, but it kind of like I'm hitting a wall. And usually that's because of a ledge formation. And what caused that? These are the reasons that you most likely had a ledge formation. You didn't have straight line access when you were going into the canal. You weren't using that irrigant or that lubricant in the canal. And I keep saying in the canal because when I was in residency at New York University, I would help the students out, and I would notice they would just be flushing that sodium hypochlorite in the chamber. It's not doing anything in the chamber. It's got to be in the root canal. That's the point of the irrigant, okay? So sometimes we also have these excessively curved canals, and if you try to widen them too fast, you're going to block yourself out. It's kind of like digging through a mine, all right? You're going to basically block that entrance. So Dr. Wiener used to always tell me, do you feel that, baby? You feel that, baby? You feel how tight that is? He always used to do that to me when I was in residency. That way I could kind of get my hands in there and realize, man, I got to loosen this thing up. So don't move on from that 10 file until it's loose, all right? I know it's cumbersome and it feels like it takes a long time, but you got to make sure that 10 file has to be loose before you even think about putting a rotary file in there, okay? So this is what I was trying to describe to you guys earlier about kind of going through that mining system. You can see how the curvature of the canal is on the picture on the left there versus on the right. They try to go too fast with a bigger file, okay? And that file starts to go off the rear of the path of the original root canal system. So this is when that ledge is formed. So now every time you go back in there with another file, you're going into the one on the right instead of, you should have been on the one on the left where it has that curve. So that's where it goes into pre-curving your instruments, starting off with a smaller instrument, make sure you get it nice and open before you move on to the next one, okay? And recapitulation, meaning that take that 10 file back out the apex again and again and keep it open and keep flushing those debris out of there. Those debris can clog up the apex there and cause you to form a ledge, all right? So these are the things I just mentioned again. You definitely always want to be using the RC prep on every single file you ever stick in the root canal system, okay? Even the hand file. Put a little bit of RC prep on the end of that thing, go in there nice and slow and open it up. Now, if a ledge does happen, there are ways to get around it, okay? And this also takes a lot of practice and a lot of patience. You're gonna have to go in with smaller files to try to open it up, 6 files, 8 files, and then back to the 10. Irrigating it and continuously going to that new working length, trying to get back around that ledge that you formed until you can get back into the original canal. But unfortunately, sometimes the canal just gets blocked permanently and you can't get back around. So that's when we may have to go in and do a surgery to get the remainder tissue that's at the apex there. All right, this one is the one that probably scares you the most, right? Other than perforations, it's the file separation. Has this happened to anybody in the room? All right, at least some people are willing to admit it. So this one over here on the left, it looks like a pretty simple, straightforward tooth. It's one canal, but still the file somehow got separated in. And then the one on the right is the one that more people probably encounter, and that's a lower molar. And the file separated in that mesial canal. Believe it or not, those mesial canals come together at the apex, and that is usually what causes the separation, or they even come together in the middle third of the root. That's why using those hand files to feel everything out is very important. Endo is a very technique sensitive, and it requires you to have really gentle touch. You want to start to feel what's going on in the root. And what happened over here on the premolar, same thing. They just didn't open the canal up wide enough before they started sticking the file in, and the torque caused the file to get locked in, and it just broke off. I remember the first time that happened to me, actually, the file broke off, the whole file. So I took my handpiece away and there was nothing at all. The whole file broke inside of the root. Same situation, it just got locked in. So I had to get that whole thing out. So these are the main reasons why you're gonna have instrument separation, okay? The excessive force when you're going in and out with that rotary instrument, you wanna be real, real light. You don't have to even put force on it at all. I was taught that you don't wanna fight the tooth, all right? If you feel like you're fighting the tooth, you're pushing, you're doing the wrong thing. You don't wanna be pushing. It should just glide right in there, okay? So keep that excessive force going. Have that straight line access, and always, always RC prep on your rotary files, okay? And I did put on here that there could be manufacturing defects in the file. Different manufacturers have different standards of manufacturing their files, and some of them are higher than others, hence the price. A pro taper costs more than an edge endo for a reason, but that's very rare, okay? One thing I'd like to point out on this slide is understanding the properties of your files, heat treated, non-heat treated. Also, you want to look at the file. Before you put it in the canal, you always measure, right? I'm going to go 21 millimeters, look at the file, put it in. When you take it back out, do you look at it again, or you just keep going to the next canal? Always look at your files every single time and see if it's starting to unwind a little bit. If it's starting to unwind a little bit, and man, don't be cheap. You own your own practice, and every file I know is pretty expensive. A pack of pro tapers is like $50 or more. You don't want to keep spending money on your files, but what's worse, spending that $50 or trying to get that instrument out of the canal, telling your patient, oh, I'm sorry, we separated the instrument in your canal. Just look at your files. They start to unwind, move on to the next file, trash it, okay? Back at the bottom there, as you can see, avoid that excessive force. Do not press down too hard on that rotary instrument there. All right, so let's say you separate the file like on that lower molar. You think it's the end of the game. It usually is not, all right? We can attempt to remove that instrument. Some GPs are actually really good at this. The first person that taught me how to get around an instrument, which is called bypassing, it was a GP. He showed me how to do it. Basically, it's a very, very time-consuming process as far as going around, trying to create a path around the file. And that's usually done with much smaller files until you eventually get around it again. But sometimes you have to send those cases to the endodontist, and we have to go in and try to get around the file if we can. We try to remove it, but if we can't, we just try to create a path around it. All right. And this picture right here is a great one I pulled from the textbook, Pathways of the Pulp. If you guys have that on your digital textbook library, or even if you have it at home, it's the book that all endodontic residents use. So if you read that book, you pretty much went to endo residency without going through the clinical part, okay? You can see what here on the picture on the left on number 1, you see where the file entered. You could tell they didn't even have a straight line access with that blue line there to kind of curving it around. So that's what caused that file to kind of get locked in. It had too much force there. So what the endodontist would do is basically try to open up that root and create a wider path so that we can try to get around with very small, fine ultrasonics to try to loosen that file up if we can, and hopefully retrieve it. Sometimes it's successful and sometimes it is not. It's a very tedious procedure. Go ahead, Dr. Hayes.
If you don't have ultrasonics, then what?
All right, if you don't have ultrasonics, you should not try to remove a file from the root canal system. You can do what's called a modified Gates Glidden. You can basically take that point of the Gates Glidden that looks like a Christmas tree. You can flatten it out, right? Basically, you got to use a burr and kind of flatten it out. As you can see in number 3 on this picture right here, that's where it says that modified Gates Glidden. They flattened it out, okay? And then you can go in and try to bypass it with the file. That's what I would recommend you do. Don't try to go in with any other instrument trying to get that that rotary file out, because you're not going to do it. What you're going to do is probably most likely perforate the root, mid-root. So just try to bypass it. Use a small 6 file slowly down until you start to get around the root. The file. Now, separated instrument prognosis. It's not the end of the world, like I said. It does happen, but it depends on how much of the canal you cleaned out previous to your separation. So that's why I keep going back to use a small file first. So if you open that root canal system up to about a 15 hand file, maybe even a 20 hand file, you cleaned out a lot of the tissue already. So let's say you're going in there, you got it open to a 10, 15 hand file, and then you separate an instrument later on, in your procedure. If you cleaned out a lot already, your chances of success are a lot higher than somebody who went in there right away with the rotary file and they separated because they didn't get the tissue out. So that's what's going to cause you the problem. So this study here, as you can see, they say if you do a root canal on a tooth that has no periapical radiolucency preoperatively, you separate a file, you still got about a 97%, 96, 97% chance of success, according to this study. So they found no significant difference there. But if the tooth already has a periapical radiolucency and then you separate a file, you can see that success rate drops like 10%. So you want to do, once again, your preoperative examination and determine what's going on with your case. Everyone can see this picture here. Anybody can tell me what happened here? Yep, irrigation, right, exactly. Somebody was just being a little bit too aggressive with the irrigation. So the main causes of the irrigant being extruded out of the canal into the tissue is wedging of the needle. All right, so what you're doing is you got your canal open a little bit and you stick that needle in and you just lock it in there. So you even try to pull it a little bit yourself, it's still in there tight, but you're like, oh, well, and then boom, they're pushing down real hard on that needle. You do not need to do that. You just gently let that irrigant do what it's supposed to do. It's like water going down a river. It's going to find its way into the canal and it's going to flush stuff out. Just take your time. You do not have to do that, okay? And I put in there, especially in that perforation that you just created. Sometimes we create a perforation in the canal. We think, oh, that's just the chamber. Or you perf the floor. You think, oh, that's just the chamber bleeding. Stick that needle in there. Boom, you just shot so much sodium hypochlorite right into the bone. And the next thing you know, the patient's swollen, they're bruising up, and they're in a lot of pain. All right, so prevention, I talked about being gentle on the needle. The one thing I also want to talk about is you want to make sure that your clinic, whether it's the clinic you're working in now or when you own your own practice, use those perforated needles. They have side vents, all right? That way the irrigant can come out in multiple different places instead of just out the end. So it's not just going straight out the end, it's kind of hitting out the sides. It'll still do the same thing, like I said, water going down the river. These needles are more expensive, of course, but like I said, it's better to be safe than sorry. Spend a little bit more money now than later on down the line. You also have the opportunity to use different irrigation solutions. Chlorhexidine, there's a new solution called BioPure. It's basically doxycycline. But all studies are going to tell you that sodium hypochlorite is the most effective irrigant. So you basically want to use sodium hypochlorite, but you got to be careful when you're using it. So let's say you do have a sodium hypochlorite accident, okay? It can be a life-threatening emergency because it's going to cause tissue necrosis, it's going to cause swelling, a lot of pain for the patient. This does not require antibiotics or surgical drainage, but what it does require is you explaining to the patient exactly what's going on and trying to get them as comfortable as possible, because that's all you can do, all right? So once you irrigate that sodium hypochlorite onto the tissue, patient says, oh, I feel it burning, it's burning, it's burning. And you start to see blood kind of squirting out the canal. What you want to do is try to take your needle in and try to pull some of that out, you know, kind of reverse suction some of that sodium hypochlorite out, and then take saline and just start trying to squirt it in there as much as you can. Like I said, but it's going to be, hardest thing is going to be keeping that patient calm, because they're going to be freaking out. Believe me, they're going to freak out. So this happened to me when I was in residency. I had my first sodium hypochlorite accident. It was on an upper tooth, and I'm talking about this lady turned black. I mean, from here all the way up, you know, over here. And it scared me, but I knew what was going on immediately. She didn't feel the pain, which was the part that kind of shocked me, but she turned black, like literally right away. So I had to just go in there and keep irrigating, and gave her a lot of anesthesia because I knew eventually that pain would kick in. And you just had to keep her calm, and I brought her back after 24 hours, 48 hours, and then 1 week, and then 2 weeks. Eventually, that all kind of went away. So basically, just follow up with your patient and try to keep them as comfortable as possible. But let them know you know what's going on and you know how to handle it, and that's going to help, you know, them feel more comfortable in your hands. All right, anybody ever done a root canal and this was the result? Anybody? Anybody stuck? There we go. All right, we got somebody willing to admit it. All right, sometimes we go in there, we obturate that canal, and then we take that final x-ray, and then we got a little bit of overextension here, okay? So this is called an overfill. Basically, you got your sealing material or the gutta percha beyond the apex. One study is going to report there's about 76% success rate with an overfill, all right? There are different criteria in that study that give them that success rate. The one I showed you, the lesion was already there, so that will cause the success rate to drop. Underfilling the root canal, being 0 to 2 millimeters from that apex, is okay, because realistically, you don't want your root canal filling to be at the apex. You want it to be slightly short, like about 0.5 millimeter. Because if we were to take that tooth out and you had your root canal filling right at the apex, we take that tooth out of the mouth, you're actually out of the tooth, because the constriction is not at the radiographic apex, it's slightly short, okay? So actually, when you take your working length films, which I hope you all are doing, you want to be maybe like 0.5 millimeter short of the actual radiographic apex, okay? And you're going to have about a 96% chance of success. That's almost 100, okay? I'm going to go back one more time because I didn't talk about being greater than 2 millimeters short. Most reasons that people are greater than 2 millimeters short is because they cause a ledge, all right? Or they just never cleaned out the entire root canal system. So as you can see, the success rate there is way less. It's about 30% less than someone who cleaned out the entire root canal system. So even if you can't get your filling in, but you know you got to the apex, you got that 20 file in there, 25 rotary, that's all you can get to the apex. But you know you got to the apex and you took an x-ray and you saw the file in there, you got the root canal clean. Even if your filling is a little bit short, it's fine. As long as you know you cleaned it and you give yourself a good restoration, you should have about a 90% chance of having success on your case. So I went back to how to prevent this. Apex locator, apex locator, apex locator. It's about 92% accurate, okay? Take a dry paper point, put it in your root canal, and then put your file in, hook it on. That's gonna give you the most accurate reading, all right? They say that there's nothing that, you know, can interfere with the apex locator as far as the canal system being wet, et cetera, et cetera. I just recommend you try to dry it. That's just going to give you the most accurate, reproducible reading, okay? And I said, don't move on to the next file unless your canal is loose. That's something I know I keep saying over and over, but you want to definitely have a loose canal. And try to stay inside of the tooth as much as you can. If that apex locator is turning red, you're out of the apex, you know, most likely. All right, so what happens if the root canal system is failing due to the obturation? If it's just a bad fill and you retreat it yourself as a general dentist, or you send it to me, the endodontist, if it's a bad fill, I'm gonna have a pretty good success rate, about 90%, all right? But if you send me a root canal that you did a great filling on, you look at it, you're like, man, this looks like an endodontist did it. You know, you're feeling good about yourself on your best cases, but it's still failing. There's about a 66% chance of the retreat working. And that is because you probably cleaned out the root canal system actually pretty good, but it's failing usually because of something else. All right, so keep that in mind. You do a great root canal. Let's just say you do a number 9, the easiest tooth, right? To all of us, you do that number 9, you're like, man, that's like the best root canal I've ever done, but it's still failing. Reassure your patient about these studies. You know, tell them that with adequate obturation, it's failing. There's something else probably going on. You're going to probably have to see the endodontist. Okay. And most likely we would have to do a root end filling ectoectomy in that case if the obturation is looking good and it's still failing. Go ahead, Dr. Hayes.
In those cases, what's usually the differential diagnosis or maybe the reason why it's failing? Could it be a fracture? Is there another canal?
Right. There could be a root fracture. It could be a missed canal. Sometimes it's just a chronic infection in the bone that just the root canal, your immune system and the root canal itself just can't get rid of all of it. So that's when, you know, you want to, if you have the CT scan, you can take that. That might give you a little more information. Or like I said, you can send that to the endodontist and we can try to figure out what's going on. But yes, usually it's going to be that missed canal, upper first molar, upper second molar. It's going to be that mesial buccal 2. Upper first molar, the mesial buccal 2 is there every time, okay? 98%, okay? MB2, that mesial buccal, second molar, it's there almost every time. I'd say like 75 to 80%, it's there, all right? So you gotta find those canals, because if you don't, the bacteria will most likely find them, and that's what's gonna cause failure. This is just to show you that apical surgery does work. It's about, I'd say, I like to round the average of all the studies because I don't believe in ever just one study. So I'm going to say you got like a 9 out of 10 chance that the apical surgery is going to work as long as they're using the modern techniques, which is the microscope and using MTA or the newer root end filling materials. Okay. Can anybody tell me what's going on in this case here? All right, this is a root fracture. You can kind of see it. I pointed the arrows there. This tooth was fractured during the post placement of the tooth and probably during also the instrumentation or / obturation of the tooth. So the vertical root fractures, usually if they're not through trauma of the tooth, they're through pressure during condensation of obturation or post-place spacement or preparation. So if you see blood in the canal after you obturate it and you're about to create a post, you use your gates or your post burrs, whatever you use, and you see fresh blood in the canal, most likely there's a fracture caused or you perforated the canal. When you're looking at this tooth, look for probing defects all around the tooth. On your x-ray, look for a J-shaped lesion preoperatively, or if they have multiple stomas, most likely they have a root fracture. All right. Here's a good CT scan picture of these teeth showing this upper molar right here. You see on the sagittal axial views that root fracture going there, and I kind of got those arrows there for you also to kind of show you what's going on. This tooth has a poor prognosis in my opinion, and most likely is going to have to be pulled. And this is my last slide here. I'm just pulling this up for you guys to show you that root canal treatment does work. So I want you guys to feel confident when you're going in there. Use the knowledge that you got in dental school and when you're getting at BronxLebanon, working with Dr. Hayes, Dr. Weiner. He's going to also be very insightful, yet quirky, but he does know a lot, all right? So ask him all the questions that you want, but use that knowledge and that competency and have your confidence going in, but make sure you're working slow and taking your time, and you'll have about an 86% chance of success on your root canals. I think that's pretty good. That's why I went into endodontics, because basically it works almost every time. All right, these are just a few reminders that I would like to put up at the end of the presentation, and just remember, be able to remember when you have to refer to your endodontist, okay? You guys got any questions for me that I can answer?
One question, you have to speak up so he can hear you.
So when you have a discrepancy for the working length between the apex locator and the radiographic working length, what do you normally go by?
I'm gonna go by, well, if you have your apex locator and it's hitting green, and then you want to take that working length x-ray, I mean, the x-ray is going to tell you where you are on the tooth better than the apex locator, because you're actually looking at where you are on the tooth. So I would take the x-ray, you know, over the apex locator, as long as you're not out the root, obviously. Any other questions? Go ahead.
How long do you usually wait to see retreatment or any other procedure? And then if the patient does require retreatment, do you always use the retreatment code?
Yes, you always use the retreatment code, and then a tooth is going to hurt after a root canal, okay? So tell your patients after you do the root canal, this tooth is going to hurt for a few days. Do not bite hard things on the tooth. Take lots of ibuprofen, give it time to heal. But patients sometimes think that, oh, I did the root canal today, tomorrow the tooth should be feeling normal. No, some patients it takes months before it feels normal again. Everybody's body heals differently. If you break a bone playing football or just walking to the metro, it's not going to feel the same, you know, right away after the doctor does the surgery. So just give it a little more time to heal and just encourage your patient, especially if you feel confident that you did a root canal treatment successfully in your eyes, and you don't see anything, reasons why it may be failing. Just give it some time and then reevaluate it, but always use the retreatment code if you're going to retreat the tooth.
Now, Doc, that brings up two other questions related to that. Is the standard of care still 4 to 6 months for following up and tracking the case? After?
Definitely. Definitely. You want to try to have at least a 6-month follow-up and then a year. That's what I like to do, at least, unless the patient, like I said, they need to come back in because of their own, you know, their discomfort level.
And then the second part of Dr. Rollins' question regarding the treatment code. So if she did the initial treatment and it's, you know, after 6 months or after a year, it has, you know, not healed or you want to retreat it, then does she have to use that retreatment code at that time, or is that retreatment code for another provider?
No, she's going to use that retreatment code at that time, but you want to make sure you know that insurance well. Make sure they don't have like a, you know, it can't be retreated by the same provider for a year or 6 months. You know, each insurance has, you know, a thick book of rules, so make sure you know what insurance you're dealing with. But yeah, you have to use the retreatment code because that's the procedure that you're performing. Anybody got any other questions for me back there?
Yep. Speak up. Yeah.
If you don't see a change in the periodical radiolucency after 6 months after you did the endo, would you retreat that right away?
So I would make sure you're taking different angle x-rays. Never rely on just one single x-ray to see if you see any changes. And then ask the patient, are they symptomatic? Have they noticed any changes in the pressure, any you know, abscesses or swellings, any drainage? Because everybody in there knows that, you know, it takes at least 6 months for slight changes to occur on the x-ray. Some patients it's going to take a year, 2 years for the healing to actually occur. Sometimes I think we try to rush things. Everybody, you know, we're all millennials in here. We want things instantly, but the body doesn't work that way in all cases. So remember that. Take your time sometimes, and it may heal slower. So just be patient.
And I think one of the challenges for us, for you all in this 1 year environment is that if someone's not taking those x-rays periodically, when you get the case, you may see it as, oh, it's not healing. Because you may only see that patient in a certain period of time. Right.
I had a guy yesterday. He came in. His general dentist wanted me to retreat it. He never had any problems with the tooth. I see some you know, lucency in the bone, but he had that treatment done 10, 15 years ago. And I told him, I don't know if this is a healing lesion, an incomplete healing lesion, or is this a new lesion? Do you have old x-rays for me to compare this to? He brought his old x-rays back, and the lesion was dark, black, nasty. And now it's light. It's, you know, it's still identifiable, but it looks way better than it did when he got the root canal. So I told him, we're not touching this tooth. This is called incomplete healing. You're asymptomatic. If it starts to bother you, then I'll go in there and retreat it. But if I just only saw that one x-ray, then yeah, I would have said, oh, we probably need to retreat this too. But because we compared it to the old x-ray, we didn't have to do anything. So make sure you have a good history of what's going on with your patient also.
Dr. Cushman, you have?
At what point does extrusion of the irrigate require medical referral?
If the patient is starting to have any type of necrosis, if you notice any, I didn't get a picture on here, but there's some where the gingival tissue just starts to necrose. You start to get ulcers and things like that. Then that's when you're going to want to get, you know, the medical team involved, oral surgery, or, you know, primary cares if you have to. Any other questions? And make sure you're up to date on your, you know, your life support and things like that. Maintain, making sure you check, the patient's airway, because sometimes with that extrusion, it can cause them to have, you know, breathing issues and things like that. So be up to date on all of those licenses also.
Dr. Scott, are any reference material that you recommend to continue to have in our side or back pockets as we do more cases, or any other types of CE that you would recommend?
Yeah, so you guys can go on the AAE, their website. They've got a lot of good, if you want to call them pocket referrals, that you can print off or you can keep on your phone. I keep them on my phone. Sometimes if a patient, wants to look at something really quick, depending on what office I'm working out of, I'll show them some of those. They're like pamphlets they created that kind of walk them through what the procedures are or what to expect. And they talk about failure, success rate. So it's all on the AAE website. And like I said, they have even videos on there. You can just click a button and it'll directly take you to a video that'll show a patient, what's going on. They've created a great site there. All right, I want to thank you guys because I think our time is running out. Just remember to email me if you have any other questions or concerns. I'm always available, dscottdds@gmail.com. And I'm on Instagram also, In Your Mouth 06. It's kind of my social media, but I also post a little dental stuff on there also.
In your mouth. Hi-yow.
All right, guys. You have a good one.
Hey, Dr. Scott, thanks so much. We appreciate you. And we'll get you back on the schedule for a couple more presentations coming up as well.
All right. Take care.
All right. Thanks, man.